Let's begin with the first speaker. I'll invite Dr. Tushar Aditya Narayan. He's a consultant uro-oncologist and robotic surgeon at Max Smart Super Specialty Hospital, Delhi. Tushar, please.
Very good morning to all of you. Thank you to the organizers for giving me this opportunity. I'll be speaking on two papers that have been given to me. I'm a surgeon, but I'll be speaking on the radiology and the pathology part of the diagnosis of prostate cancer and how artificial intelligence is changing the landscape. The first paper is Artificial Intelligence and Radiologist in Prostate Cancer Detection on MRI. This is the PI-CAI study. This is an international paired non-inferiority confirmatory study. So let's start off. This was published in the Lancet Oncology in 2024, in June 2024 last year. And to give you a brief background, AI systems obviously help us in the diagnostic pathway of cancer, prostate cancer, by decreasing the workload of the radiologist, preventing overdiagnosis, which is a major concern in prostate cancers, and reducing the dependence on experienced radiologists who are not experienced in radiology can also use this to detect prostate cancers. And the authors in this study aim to investigate the performance of AI system at detecting prostate cancer on MRI using the PI-RAD score, and this was compared to the general radiologist. So I did, all this was not mentioned in the paper, so I did a brief background check, and I went back and I found that this PI-CAI study was hosted by the Amazon Web Services, AWS. They have an online website which you can check, grandchallenge.org, in which they invite individual companies and developers to develop their AI deep machine learning tools. And for this prostate cancer detection on MRI, they had 192 applicants. And in that, the top applicant was selected by the Amazon Web Services, and their data and their algorithm was used in the study. And in this small box here, you can see what were the inputs, the different sections on the MRI, the T1, T2, and the ADC curves. And the outputs were the case level, the patient level, and the radiology level prostate cancer diagnosis. So this AI model used about 10,207 MRI examinations. This was used to train the AI model. The data was fed of about 10,000 patients, and then another 1,000 MRI were used to evaluate this AI model. And the comparator was 62 radiologists who were expert in reading prostate MRIs. This was all over the Europe, mainly in Netherlands and Germany. And there were about 400 MRI readings by 62 radiologists. The other comparator was the readings from a multidisciplinary tumor board, in which the urologist, the radiologist, and the medical oncologist sat together and decided the MRI findings. So the comparator was 400 MRI readings by just the radiologist and 1,000 MRIs in the MDT board. The primary endpoints were the sensitivity, specificity, and the area under the receiver operator curve for this AI tool. And the benchmark was the histopathology, the biopsy-proven prostate cancer, and 3 years follow-up. That was the reference standard. Coming to the results, of the 10,200 examinations, about 2,440 had histologically confirmed prostate cancer. Now, comparing the 400 radiology MRIs, which were compared with the radiologist and the AI system, the AI system showed a statistically superior and non-inferior area under the receiver operator curve of 0.91. So this was the first a non-inferiority study. So they showed that it was not inferior. The AI model was not inferior to the radiologist. Where you can see the AU ROC for the 62 radiologists was 0.86, while that for the AI model was 0.91. So this was the first thing that they established, that it was not inferior. They took PI-RADS 3 and higher as the cutoff, and they found that the AI model detected 6.8% more cases with Gleason grade 2 or higher, and there were almost 50% lower false positive rates with Gleason grade 1 at the same sensitivity. That's PI-RADS 3 and above. This was as compared to the 62 radiologists, the 400 cases. When this was compared to the multidisciplinary team meetings, the AI model did not fare as good as the MDT model. And the authors in the discussion have probably said because in the MDT model, the clinical data was available, the PSA values were available, hence the radiologists were more confident and more sensitive in picking up the lesions on the MRI as compared to just the radiologist who did not have the clinical data. So in this, when compared to the MDT meetings, the AI system showed lower specificity. So this is the area under the receiver operative curves. So I want you to focus on the lower two figures. So this is the first one is the comparison with 62 radiologists, in which this favors the AI system. The sensitivity and specificity favors the AI system. But then again, when compared to the MDT did better than the AI system because of lack of clinical data with the AI system. So to conclude, AI system was superior to the radiologist using the PI-RADS2 at detecting clinically significant prostate cancer. AI was not superior to the MDT detection of prostate cancer. And this study provided evidence that AI systems, when adequately trained, could potentially support the diagnostic pathway of prostate cancer management and decrease the workload on the radiologist. So this was the conclusion of this paper. Going on to the second paper, this is a similar paper, use of AI for detecting prostate cancer on biopsies. And this is a confident P trial. This again is a very, I went back to this company's page, the Page Prostate. The Page company runs a lot of AI diagnostic tools for pathology reading of different cancers. So it's confident P is prostate, confident B is breast, confident C is colorectal. So I went to the page for Page Prostate Cancer, and they've already developed their AI tool for detecting prostate cancer. And their website said that this tool, the Page Prostate tool, enhances the efficiency, obviously decreases the time taken for reading these slides, reduce diagnostic turnaround slides. It supports a confident diagnosis and can reduce the need for immunohistochemistry, and that in turn can result in cost reduction. This paper focused on just one aspect, whether need of IHC for detecting prostate cancer was decreased or not when we use this Page AI tool, and this is the Confident P trial. This was published in the Journal of Clinical Oncology in, I think, March 2025. So a brief synopsis. This prospective clinical trial evaluated whether an AI-assisted workflow for detecting prostate cancer in prostate biopsy reduces immunohistochemistry while maintaining the diagnostic safety standards. So a little background, when do we use immunohistochemistry in prostate cancer? When we have negative biopsies, we want to make sure that it's negative and not positive. When we have doubtful lesions like lesion 3+3 and 3+4, whether there is adenocarcinoma or there are no lesions, and to distinguish intraductal carcinoma from cribriform lesions. So PIN in prostate cancers have cribriform lesions, and IDC in prostate cancer also have cribriform lesions. To separate these two, we need IHC. And the two most common IHC markers according to the ISUP guidelines are the P53 and AMACAR. P53 is present in normal tissue. It's not present in malignancy, while AMACAR is present in malignancy. So these are the two IHC markers that are most commonly used in these doubtful lesions. So this study said that if we use AI, can we reduce the use of these two markers to confidently say that yes, cancer is present or cancer is not present? So the methodology, patients suspected of prostate cancer were allocated bi-weekly to either a control or the intervention arm. Intervention arm was the AI supplemented pathology reading. The control arm, the pathologist, the regular H&E staining and IHC staining on whole slide images. And the intervention arm was the Page Prostate Detect AI algorithm on HE slides. This algorithm was integrated into their software of the digital workflow for the pathologist when they were reading the slides. And in this intervention arm, IHC was done only if the AI tool also did not confidently detect prostate cancer on these slides. So about this model, the Page Prostate Detect Artificial Intelligence model. This is a neural network which has been trained on 32,000 cases. This was the data fed for training this model, out of which this 6,700 cases were from MSKCC, besides other 44 international laboratories. And the output is a binary prediction, whether it's benign or suspicious, highlighting regions with highest likelihood of harboring cancer. This is a two-arm intervention trial which alternated the prostate biopsy samples bi-weekly between the control and the AI arm. This is not a randomized control trial. In the control arm, pathologists assess the H&E slides with IHC available from start. Sorry, I'll just go to the results. In the AI arm, there were 109 slides. In the control arm, there were 130 slides. And IHC was used in 68.8% of the slides in the AI arm. And the reasons for use of IHC in the AI arm were that in 37 slides, it was benign. 19 slides, it was uncertain. The pathologist could not come to a diagnosis. And another 19 slides, they wanted to differentiate cribriform from intraductal carcinoma. The use of AI reduced the relative risk of IHC use on both the patient level and the slide level. At patient level, the relative risk was 0.55, and at each slide level, the decrease of IHC use was 0.541. And this in turn related to cost reductions, because obviously IHC is associated with cost increments. And there were 34 slides that did not need IHC in the AI, and they have roughly figured that each IHC slide costs about 50 euros. So in this study, they saved 1,700 euros because of not needing IHC on those 34 slides. So results, I'll come to the conclusion. AI-assisted pathology reading reduces the need for IHC. It improves the efficiency, quicker reporting, and decreases financial burden of immunohistochemistry. And AI assistant improves the sensitivity and negative predictive value of pathologist reporting. So these are the two studies, one on radiology and one on pathology. And obviously both the AI-assisted tools have helped the radiologist and the pathologist. Thank you.